Hi everyone, I'm Dr. Michael Miyazaki, and today we're going to talk about something a little bit different. We're not going to be talking about a product or a piece of equipment or how to restore a tooth. We're going to be talking a little bit broader today. So one of the things that I experienced this last week was I taught a live patient treatment program, and the program was focused on dental aesthetics. Now, dental aesthetics today is very different than it was 30 years ago when I was learning. 30 years ago, when we were talking about dental aesthetics, we weren't talking about composites, but we were talking about something called veneers. And veneers were these thin shells of porcelain that we could put over teeth. And we were taking patients basically with any kind of bite, crooked teeth, and we would prep them down and put veneers over the tops of them. And they'd have that beautiful smile they always wanted, the ideal color, the ideal shape. They had that smile. But one of the things that caused was veneers popping off, veneers breaking. And so we as dentists kind of sat back and said, okay, what's causing these veneers to fail? Well, undoubtedly it was occlusion. And going back, when I graduated from dental school, I graduated and I thought that dental implants were going to kind of be my niche. I always thought that they're really interesting. But as I went to more courses, they would say dental implants are a great service, but they could fail. And the main reason why we were told they were failing a little over 30 years ago wasn't because of the implant design, it wasn't because of surgery, it was because they were loaded improperly. And by that, they meant that the bite wasn't quite right. The implant had integration with the bone, it didn't have a PDL, it couldn't absorb the stresses like a natural tooth could. And if you overloaded it, especially with lateral forces, that implant was going to fail. Well, unfortunately for me, I graduated from dental school and I went to a great dental school that was very, very heavy into occlusion. But as a dental student, a lot of it just didn't soak in. I was trying to figure out how to get a margin on a crown or how to get my amalgams to be perfect so there was no catch at the margins and not overfill it. Occlusion was just trying to get the dots even. So if I was working on, let's say, tooth number 19, when I got done with that amalgam, I wanted the patient to say the bite felt even. And so that was kind of my thinking about occlusion. Occlusion was getting the bite even. And then it kind of matured, and then I was trying to avoid lateral stresses on those posterior teeth. So I was really trying to get anterior guidance or cuspid guidance or disclusion. And slowly over the years, my understanding of occlusion has kind of matured. Another thing that happened the last couple decades is the approach to airway. So airway became a big thing, and what we know now is that airway and TMD have a relationship with each other. So if somebody has TMD, we want to see if they've got an airway issue. If somebody has an airway issue, we like to see if they've got a TMD or joint issue. So I, at that point, a year out of dental school, realizing where my weaknesses were, kind of delved into the function of the teeth or the occlusion. So what I want to talk to you about today is it's not always about the even distribution of the dots. Because again, I would try to do one filling, and I'll do a filling tomorrow. And when I do those fillings, I'm going to have the patient bite on my articulate paper, and I'll ask them, how does the bite feel? What am I going to ask them? Does it feel even? In most cases, if you have a patient and you've looked at them and they don't have TMD or they're not prone to TMD, you're probably going to be just fine. On the other hand, we don't want to overtreat everybody. So if somebody is functioning just fine with the occlusion that they have today, they probably will function there most of their lifetime, if not their entire lifetime, and be just fine. And why is that? Well, we'll talk about that coming up too. All right, so let's talk about this. Who are the players in the system? Well, we know we have the teeth, and the teeth are the players that we interact most with as dentists. Well, what are those teeth implanted in? The bone. And that bone is connected to joints. And these joints are complicated because it's not just one joint, but it's two joints that are connected by the mandible. We have one on the right and one on the left. And these joints don't just rotate within the socket, but they translate. I mean, they come down and forward. So they can actually kind of come out of that socket. So they have a lot of travel. So they can rotate and they can translate. Well, what makes the bones move? It's the muscles. Well, what makes the muscles move? It's the central nervous system. And when you throw all this together, why are some patients such that they have a really bad bite, but no TMD symptoms, no airway issues. And other patients seem to have a fairly good bite, and they have all the symptoms you could ask for. Pressure feeling behind the eyes, pain in the jaw joints, clicking, popping jaw joints, headaches that radiate across the crown of the head. They've got everything that one would look for as symptoms of TMD. Well, I think we have to understand the players. So this is a patient that I've been treating for the last month or so. And when you look at her model, she's got a fairly deep overbite, not quite 100%, but the upper centrals have a lot of wear and the lower centrals have wear also. And we're covering the lower centrals by about 60%. If you look at the anterior teeth, the two centrals are tipped back, so we're kind of a class 2 div 2 because the laterals are kicked out facially. Now, this patient comes in complaining of TMD. First thing I ask is, well, how's your bite feel? She goes, my bite doesn't feel very good. I'm hitting more in the back, not so much anywhere else. Now, being a traditional dentist, what I would be so inclined to do and tempted to do would be to pick up my articulating paper, blue or red, stick it between the teeth and say, bite down in your normal bite. Ah, yes, you've got one, say, blue dot here and one blue dot there. It's not very even. I can see why you've got TMD. And what we're tempted then to do is to fix everything by grabbing our burr and taking those blue dots off, or maybe repositioning them, reshaping that cusp or that central groove, wherever that blue dot may be. But if we're evening out those dots to get that even distribution, my question to you is, do we have the right bite? By that, what I mean is, again, I went to a great dental school, and what we had to do is we had to do jaw tracings. And in those days, we had an articulator, we had a flag system, and what we would do is we'd manipulate the mandible and find that pivot point. And around that pivot point, that would be our reference point that we might then begin our treatment. Do we do that today? With most patients, we don't. Now, I know there's some dentists out there that are very meticulous, and they will hook the patient up to a jaw tracking system of some sort and try to really figure out what's going on. What the majority of us do is we just throw the paper back there and say, bite? How does that bite feel? What I want you to think about is, what is this bite showing you? So when you go back to your office tomorrow, you see a patient, maybe a minute from now, you'll be thinking about this. So the way I explain it to my patients is that we have a concavity in the skull. Into that concavity fits the jawbone. But so that two bones aren't rubbing against each other, like on our elbows and our knees, we have a little piece of cartilage up there. In dentistry, we call that the disc. And what we want to do is we want to have that jawbone rotate. I'm going to mention these terms to you as clinicians. We want this bone to rotate and translate and stay on that cartilaginous disc. That cartilaginous disc is kind of made to bear that load in that movement. It doesn't have any nerves in it. But if we take that condyle or that jawbone and we push it back towards the ear, then we are on what's called the retrodiscal tissue, where there are blood vessels and nerves. And that's why one of the tests as a CR doc would be, we take the lower jaw and we push it up, either superior anterior or maybe rearmost uppermost, depending on what your definition of CR is. But we're loading it to see if we elicit any kind of pain up there, if that condyle is pushing on the retrodiscal tissue. And if it is, that's not a good thing. We're going to try to reposition that condyle back onto the disc or maybe onto a pseudodisc. But we want to try to keep it off the retrodiscal tissue. I followed many different philosophies of occlusion. When I first got to dental school, I was following the habitual occlusal bite. Okay, you just bite down. As I got deeper into this, I was a Pierre Dawson follower, so I was doing a CR bite. So for the next decade, every patient that came in, we had little Daylar wax wafers, and we'd warm it up, place in the patient's upper arch, and manipulate the mandible into that wax wafer and mount their models. So that way we could begin to diagnose their occlusion. And then I got into the neuromuscular approach. And with the neuromuscular approach, I had equipment now to quantitatively look at what's happening to muscles and to the jaw joint with some really good jaw tracking. So that's what I'm going to be using today. What I would tell you is, think about whatever occlusal philosophy you follow. Think about how it works. Think about that philosophy. I use the equipment now to show and demonstrate to the doctors that I teach what's happening within the stomatognathtic system. The stomatognathtic system is basically those players all wrapped into one. So we're not just looking at the teeth, we're not just looking at the joints or the muscles of the central nervous system, but we're looking at everything as a whole. And one adjustment to a tooth could affect the joint position, which could affect what the muscles have to do, which could then activate the central nervous system and maybe some type of avoidance behavior, and the patient now has more TMD. If I look at this patient, this is what the models are showing us. You can see how the central, especially the right central, tooth number 8 or the 1-1, is kicked back lingually. If you look at the lower teeth, what is that lingualized upper tooth going to do to the mandible? Think about that for a second, because I want you to think about your patients this way when you see them. What is the function? Now, if the patient isn't hitting the front teeth, what they could have learned is through muscle engrams, basically muscle patterns, is to pull the mandible back. If they pull the mandible back, the mandible is connected to the condyle is going back in the fossa, and what did we say was on the back side of that fossa? The retrodiscal tissue, the nerves and the blood vessels that we don't want to impinge upon. So that's what I'm starting to think about. I'm looking at this patient. I had her buy on some reticulate paper because I wanted to see where the blue dots were. They're fairly evenly distributed, but are they on inclines? Are they shifting the mandible? And are other teeth shifting the mandible anterior posteriorly? Is there a lateral shift? What's happening to the midlines? Those are some of the things that we have to think about. So with the equipment that I have, we take a little magnet and we put the magnet down between the two centrals, 24 and 25. And our equipment will track where that magnet travels through space, how fast it travels, and we can see it kind of live. So this is what a scan might look like. And to tell you the truth, let's kind of avoid this area right in here right now. And let's focus over here. So in this area, this is a sagittal view. And the sagittal view just means we have a side view of the patient. So imagine that magnet. That magnet is just going up and down, right down here. So this line right here, that's just showing that every second and a half, the mandible is going up and down. And we're going up and down almost a millimeter. During that time while the patient's mandible is going up and down, and this is done using a TENS unit, a transcutaneous electrical neurostimulator with a little 9-volt battery, the mandible is just going up. And we had the patient do this about 45 minutes. During that 45 minutes with this ultra low frequency TENS unit, we're relaxing the muscles. The muscles are beginning to relax. As they relax, more blood gets into those muscles. So the lactic acid is removed and the muscles begin to heal up. So what I do is I put our apparatus on the patient with a little magnet and we track what's happening. What the computer is showing us in real time is the mandible is traveling up and down this path. Now I have the patient just rest their mandible down. This yellow line, that would be our ideal vertical as is established sort of mathematically. So I had the patient lower the mandible below that yellow line, and I'm letting the TENS unit raise and lower the mandible once every second and a half. When the patient's relaxed, I ask them to bite down. Now I ask them to bite down to the habitual bite. So they go from this position and they follow this line up, and this is where their CO bite is, right there. The computer says, well, before the teeth were hitting and before the teeth could govern where the mandible went, remember the two centrals are kicked back lingually, so the body has engrammed or muscle patterns that signal it to pull the mandible back. So what the computer says is with the teeth apart and not touching and no cusp-fossa relationship, no lingual tooth structure on the uppers to fit the lower facial incisal edges of the lower teeth behind, the computer says this is the path that the mandible would prefer to follow, right here. And then right here, the difference between the habitual CO bite position and the physiologic bite position is about 2.5 millimeters. Meaning every time this patient bites down, the mandible has to be retracted 2.5 millimeters. That's pushing the condyle posteriorly, and it means that the muscles cannot just go up and down, but as they go up, they have to pull the mandible back. Now you think, well, I'm sitting here and my jaw is kind of hanging down, my teeth aren't together. But 2,000 or 3,000 times a day, unless you have a tongue habit where you put your tongue between the teeth are coming together. So 2,000 or 3,000 times a day, your mandibles having to be retracted to get the lower incisors behind the upper incisors. So what's that do to the muscles? A little bit of quick anatomy. Down here, we've got 4 muscle pairs. We have the right and left anterior temporalis, the left and right masseters, the left and right cervical group, and the left and right anterior digastrics. The anterior digastrics are underneath the mandible. They are depressor muscles. They drop the jaw when they contract. The posterior cervical group, the CGs, those are more neck posture. So we have some patients that have a very severe head posture, and we have other people that have good head posture, and other people that their heads flip-flopping every way. We've got the masseters. The masseters, I tell patients, are the clincher muscles. They're not really activated until the teeth feel something between them, like a steak. Once we get that steak between our molars, now we can clinch down with the masseters. The anterior temporalis muscles are kind of the position muscles. They're kind of a fan-shaped muscle. There's the anterior band that goes up, the middle band that goes diagonally, and the lower band that goes posteriorly. So this muscle is well situated to move the mandible because we have temporalis muscles on the right and left side. The fibers go up diagonally and back. And depending on what that muscle does, it can pull the mandible back and get it into position so the teeth don't hurt themselves when the bite is there. So as I'm looking at these bars, position number 1 and 2 are kind of our CO. That's where I just ask the patient, close down gently, and I measure the EMGs. And we see that there's these bars right in here that are really, really high. This is the right anterior temporalis and the left masseter. As I reposition the jaw, I ask the patient, just let your jaw hang down. So now we're down here at number 3. We can see what happens. We get these muscle readings down here, and the height of these bars is much lower. What I then do is I ask the patient, relax your muscle, your jaw, and then float up and allow your jaw to find these areas. Because if I look at this, what I'm after is I'm looking for a low muscle activity. One of the things that I've learned is a lot of the occlusion camps believe that muscle hyperactivity is a cause of TMD. So what I'm trying to do is I'm trying to find where the muscles are most relaxed. And so that kind of takes these top positions out because we've got these high bars, and has me looking down here where we've got the lower, these are muscle EMGs. The way that we get the muscle EMGs is we actually put pads on those muscles, and we're measuring in microvolts what the electrical activity is in those muscles. If the muscles are working hard, the bars go up high, and that's not a good thing. If the muscles are more relaxed, there's not a lot of muscle activity, and that can be a good thing. So here you can see there's a big difference in this area. So how do I get the bite? Like in this number 3 area, because I can see this in real time, I ask the patient, just rest your jaw down, so maybe the jaw's down here, and I say, okay, just allow your mandible, your lower jaw, just to float up, float up, float up. Okay, hold right there, freeze. And from a frontal view, what I want to do is, here's the midline and the habitual bite, and you can see that physiologically when the teeth are engaged, we're not quite a millimeter further to the right, but just a little bit more. So in real time, I can watch the mandibles, they float up to this number 3 spot, and I can see them as they float up to this area, and so I can mark those points as my target, and then take my bite registration at that point. So I have my low EMGs, I've got my 2 target points I put in these big red circles, and I just guide my patient there, and we take our bite registration. Now with this bite registration, what I've tried to do is I'm disengaging the teeth. So I'm trying to open the bite up enough that the lower incisors don't bang into the linguals of the upper incisors, that those little dots that I was seeing before really aren't affected because I'm going to make an orthotic, and there's many different orthotics, so I don't want to get into that right now. But I make something that's acrylic to go between the teeth to hold the lower jaw in a better maxillomandibular position where the muscles can be relaxed. In this position, the joints and the muscles can begin to heal, the inflammation begins to go down, the central nervous system can forget about all the avoidance engrams that it's learned and just have the functional pathway called the physiologic trajectory, and then just allow the patient to feel better. So I saw a patient today. She has a myoliner. It's a very aesthetic looking orthotic. And what she was telling me, she came in for her third adjustment. When I deliver these orthotics, I tell the patients that they may take some adjustments. Why? Because day one, I get the best bite I can. But on day one, they still have damaged joints, so to speak. The muscles are still tight. There could still be inflammation there. And all that central nervous system engramming is still intact. As they wear the orthotic and things begin to relax and the jaw begins to change its position to get into a more physiologic spot, then I adjust the orthotic, the acrylic. We're not grinding on teeth. We grind the orthotic, or we can add to the orthotic to allow them to find that comfortable position. And now they begin to heal. So going back to the story today, I saw a patient. She came in for a third adjustment. We think we pretty much have her there. But the first day she left, she thought the orthotic felt pretty good. The second time she came in, she felt like she was hitting the lower cuspid areas a little too hard. It was pushing the mandible back. She wanted a little bit more freedom. Today she came in and basically the same thing, but now she felt like the orthotic may have been causing her jaw to shift just a little bit to the side, and the one on the right hand side was teeter-tottering a little bit. All good things. I always tell my patients, I go, when we have to adjust the orthotic, it's a good thing because that means that things are healing and the bite is changing. So then we just adjust the acrylic of the orthotic to balance that bite out. So when she left, she felt good. She's like, I can clench down and everything feels comfortable. That's what we're after, and that's why we don't adjust the teeth, we adjust on the acrylic. And now her healing begins. So I hope this gives you a little bit of an insight into how you can look at occlusion. If the occlusion is forcing the mandible back, not only are we going on that retrodiscal tissue, but think about what that's doing to the airway. When we're doing our TMJ assessment, one of the things that we're doing is we're looking at the tongue. How wide is it? How is it fitting within the constraints of the mandible? Because that can have an effect, and we can talk about all that more later. If you like the information, please hit subscribe and keep coming back and share this with your friends. We're really just trying to create a community to share ideas. And if you have different ideas on things like occlusion, which there are many different ideas out there, please, share your thoughts. We want to be an open-minded community. And I think one of the things is you can have different thoughts about occlusion or function in dentistry. But one of the things we all have to do is we all have to understand the principles. What are we after? I always tell the doctors that I'm training, if you have a way that allows you to achieve success, defined by whatever parameters it is that you seek, more relaxed muscles, better occlusal stability within the teeth themselves, healthier joints, central nervous system that doesn't have a lot of engramming avoidance behaviors that are causing the pain, then that's great. One of the reasons why I use this equipment is because I can show you. Instead of just saying, I moved the patient from here to here in their bite and they felt better, I can show you what their EMGs are showing me, and then when we have the orthotic in, how we're on that trajectory. So in that example I showed you, how the patient, every time they bit down or swallowed, the mandible had to go back 2.5 millimeters. In the current orthotic, they no longer have to do that. So let's keep sharing, let's keep growing, let's just keep having fun in our careers. Thank you very much.